Hello, everybody. On behalf of Moffitt Cancer Center's Thoracic Oncology Department and the LATTE program, we want to thank you for being here today. We've got such a great-looking group. I want to personally welcome you to the program portion of today's forum. I hope you all had a chance to get a bite to eat, see our resource and education table, give us a handprint, and maybe even see some of our research labs. My name's Olivia Fridgen, and I coordinate our LATTE program here, and I'll be your MC for the day. If you're new to our LATTE program, our mission is to contribute to the cure and prevention of lung cancer by embracing the family and patient perspective. The program offers educational components such as our web seminars, our newsletter, and the forum like you're at today. We also have a great group of research advocates, and we will soon be launching our LATTE VIP, or Virtually Involved Patient and Caregiver Network. It's an online opportunity for lung cancer patients and their families to connect with our program. I'd like to let you all know that we're recording the presentation today for patients who are unable to be here and they can watch it at a later time. So I'd also ask that you hold all your questions till the end. We'll have a designated special question and answer period. And if you prefer not to be on camera during that question and answer, please use the cue cards that I passed out and I'll collect those and ask our presenters on your behalf. If you don't mind being on camera, we'll have a wireless mic that we can pass around and you can ask their questions directly. We have a really exciting panel for you today. We hope that through this presentation you get a chance to meet some of the thoracic oncology patient team members. Some of these you'll meet in the clinic, but some of these are behind the scenes as well. And they'll share a brief snapshot of what they're currently working on in their respective specialties and how that impacts lung cancer treatment, research, and support. Lastly, we'll hear from three of our very own patients, lung cancer patients, and caregivers. For the sake of time, I'll briefly introduce each speaker, but if you'd like to know more about their background and their full biography, please see the program that we passed out. It has all of their information in there. So now I'd like to start by introducing our first presenter of the day. Dr. Scott Antonia is the chair of the Thoracic Oncology program here at Moffitt. We'll be highlighting targeted therapies, including immunotherapy and ongoing translational research.
Thanks, Olivia. And thank you all for coming. We appreciate it. You know, this is a disease, as you all know, just as well as me, that's been a disease that really hasn't received much attention, and there's been a lot of pessimism about this disease. It's been a scary disease. And so, but as many of you in the room know, there is a lot of hope for this disease now. There's been dramatic improvements, major leaps in the way that we treat this disease. And so you all coming here today and participating in this and understanding more about the disease and being advocates and spreading the word that there is really hope that's now associated with this disease is very important. There's not only hope for the treatments that we can offer people today, but I think what's far more exciting is the fact that we're really on the cusp of making even more leaps. We've accrued enough information to know that we're on the right path with a lot of these systemic therapies that are working pretty well now, but we're not helping everybody. But we know enough now about the science that if we do just a little bit more research, then we're just going to increasingly add to the number of these and types of these treatments that we have to make people do better and better. So it's still very important, of course, that we haven't displaced the usual way that we treat lung cancer, right? Still, the best way to treat lung cancer is with an operation in people who have disease that hasn't spread. That's still the best way of curing this cancer. And one of the developments that has occurred recently is that it has been proven in a well-done randomized clinical trial that screening for lung cancer using low-dose CAT scans in people who have certain risk factors for lung cancer actually saves lives. And again, this is something that is very hopeful, but hasn't received much attention. And even though we've known this now for the past year or so, and we've been advocating for people getting this screening because we know that we save people's lives, the uptake has just been very, very low. So spreading the word about this is very important from folks like you as well. You know, in primary care offices, you all go. If you're a woman, you get a recommendation to get a mammogram, to get a pap smear, to have your prostate checked, to get your cholesterol checked, to get your blood pressure checked, all of these screening things for other diseases. But turns out CAT scans for lung cancer just as effective as all of those other things in terms of saving lives, and yet it's not very often ordered in people. So once again, getting the word out, and we're doing the best that we can through lots of different avenues, going directly to the primary care physicians and doing advertising, etc. But again, advocates such as you spreading the word for people who don't have lung cancer but who are at risk for it, smokers or previous smokers. Getting getting into a CAT scan screening program could save their life. Very important. We still use radiation a lot. Radiation helps a lot. Radiation cures some people who have disease that we can't take out, especially this stereotactic body radiation, really focusing the radiation on small tumors in people that can't be removed surgically, has been a major development over the past several years. And then for people whose disease has spread, a disease that we still really can't think about curing, we're really approaching this much differently today than we did even 5 years ago, and all we had was chemotherapy. We knew we could help people, we could make people live longer, but we really couldn't think about turning it into a chronic relapsing disease that people live with for weeks and months and now years. It's not everybody that derives that great of a benefit, but it's not unusual. And I approach every single one of my patients now as that person that we can turn that metastatic lung cancer, advanced lung cancer, into a chronic disease that people can lead a normal life with, and that we just treat month after month, year after year, and people live for a long time. Not everybody, but I can introduce you to people in this room who I've been treating for years with metastatic lung cancer, and you wouldn't be able to pick them out just by looking at them. They're leading normal lives, they're feeling well, and they're living with this disease for years. Again, something we really didn't think about that we could do very often, even 5 years ago. And so what has happened that has made that possible? Well, first of all, we still use chemotherapy. Chemotherapy still has a role. Chemotherapy still works. Everybody who has metastatic lung cancer, most people get chemotherapy. But the advances that we've made over the past several years is that we have made it less toxic. So even when we do use chemotherapy, people usually lead pretty normal lives. They don't get very sick from it. On average, most people do okay with it. But in addition now to chemotherapy, we have these other modalities, systemic modalities of treatment, different categories of treatment that work throughout the body in patients who have metastatic disease. And in addition to chemotherapy is one of those. Another thing is anti-blood vessel therapy. So, if you can, what we have are treatments that kind of soak up growth factors for blood vessels, so that we can kind of simply thinking that we can stop blood vessels from growing into a cancer, then we can starve it, and that's effective. And almost always we give it in combination with chemotherapy. And then the other major advance has been molecularly targeted therapy, and you hear more about this from some of the other speakers today. But it turns out, not so many years ago, it was discovered that in some people, there is a mutation in a particular gene called the epidermal growth factor receptor gene. That if they had a mutation in that gene, it would lock the protein that gene coded for into the on position. And this is epidermal growth factor. So if you lock a growth factor receptor into the on position, it's going to grow all the time. And that's what cancer is, right? Just cells that are growing in uncontrolled fashion. They're just growing all the time. Well, we're always pessimistic that we would be able to just give one thing that hit one target and be able to help people. But it turns out we were surprised. It's the case. that there are in some people these driver proteins, these abnormal proteins that all you need to do is hit that one protein, and you can have a significant impact on the disease. And that's the case with the epidermal growth factor receptor mutation. Now, it's relatively uncommon. Probably about 10 or 15% of people have these actionable or mutations that we have some treatment that we can give and do something about. But these are, again, I could introduce you to people in this room who have been on these treatments and on these treatments for years. So that's where we were several years ago, just that one gene. But now every year that goes by, we're adding to the list of these driver mutations. So and treatments are now, we just have two now that there are commercially available drugs that can hit them, and that's that EGFR and the other one called ALK, A-L-K. Again, they work very well. They work in most people. They can work for a long time, and it's just one more arrow in our quiver that we pull out that we can shoot at this disease for those people who have those mutations. And now we're finding even more. So now it turns out that we have a drug that can hit ROS, and we have one that can hit BRAF, and we're working on ones that hit MET and RET, etc. So there's a bunch of these other genes that now we're just increasing the number of these mutations, and so the number of people that we can give these relatively non-toxic pills to and have a dramatic impact on their disease. So that's molecularly targeted therapy. And then the other thing that has just occurred over the past couple of years was a surprise to all of us, including me. I'm an immunobiologist scientifically and a lung cancer doctor medically, and I never thought that we'd be able to use immunotherapy for this disease, but it turns out it's a very immunotherapeutically responsive disease, and that has resulted in a major advance in the treatment of this disease. These are treatments that don't do anything against the cancer itself, right? These treatments just allow people's own immune system to kill their own cancer. And really what we've found is that the reason why so it's an obvious point not an obvious point, but it's a point that tumor cells are genetically unstable. So they have a bunch of mutations in a bunch of different genes. And genes produce proteins. So if it's an abnormal gene, it's going to be an abnormal protein. And so our immune systems are outstanding. We reject a bacteria that invades us, or a virus that invades us, or an organ that gets transplanted into us. Our immune systems work very well. They should be perceiving lung cancer as foreign, right? Because those cancer cells, every single one of them, has mutations in it, making abnormal proteins. They should be perceived as foreign and rejected. Well, it turns out what we've found in the past several years is that sometimes those mutations can actually turn on ways of evading the immune response. They have ways of flipping an off switch on cells of the immune system that are designed to kill cancer, lymphocytes. And so what we've developed are antibodies that can bind to the off switch on those lymphocytes and shield it. So no longer can that tumor cell flip that off switch on that lymphocyte, so those lymphocytes can now kill their cancer. And it shrinks, it either stops the growth of lung cancer or shrinks it in about half of people. It's a lot. You get major shrinkage in a quarter of people. And it looks like we're having a major impact on the survival. So, back in just when we just had chemotherapy, we could expect that only half of people would be alive a year after they were diagnosed. Well, now, we think that we may be even close to doubling that time. And that's not even the most exciting thing for me and for people who have this disease. The most exciting thing is it looks like we're having what we call an impact on the tail of the survival curve. In other words, when people have a response to these immune therapies, it can be very durable. They don't develop resistance. Not everybody, but some real fraction of people do. And so we now have people that are living 3 and 4 years with this disease who remain in a good response. And we'll actually hear from somebody who's been living with a near complete response, no active cancer for years now because of these immune therapies. And I just say 3 or 4 because that's just how long we've been using this. We're beginning to even whisper the word cure for some people with metastatic lung cancer, something that would have been an absurd thought even, five years ago. So again, lots of hope for the treatments that we have today. We're not helping everybody, and there's still a lot of people we don't help. And therefore, it's still critically important that we advocate for and support the research mission of places like the Moffitt Cancer Center and you all. And again, I can introduce you to many people in this room who have contributed to this by participating in these clinical trials. We here at Moffitt now are saying we're taking these antibodies that I talked to you about. They're called anti-PD-1. You've heard of them. They're Opdivo or Keytruda. And we're combining those with X and with Y and with Z to try to see if we can increase, that the fact that we're helping half of people to more than half of people. So I probably said too much. Did I? Anyway, are you taking questions now, or what's the? No questions. She's not allowing it. So anyway, thank you all for listening. Thank you again. Thank you all for coming, and Olivia, move things along.
Thank you, Dr. Antonia. I promise we will get to questions, just not quite yet. Next, I want to introduce our presenter, Dr. Todd Knepper. He's a pharmacist by trade and will be showcasing how Moffitt's personalized medicine department can assist patients and physicians in treatment decisions.
Thank you. So my name is Todd Knepper, and I'm a personalized cancer medicine fellow here at Moffitt. I've been here for a little less than 2 years by way of University of North Carolina, and I'm really happy with my being here at Moffitt. So I want to thank Olivia and Dr. Antonia and the organizers of this event for inviting me to take part of such an esteemed panel, and to you all for coming and being part of the Moffitt team and the Moffitt family. So you may have heard of the term personalized medicine or precision medicine, and the idea of that is using specific information about a patient in order to select their care, tailor their care for them. In the cancer space, we often think of this currently in terms of tumor genetic sequencing technology. And this is because at its core, at the core of cancer, genetic mutations are there. Its normal cells develop a series of mutations which confer a survival advantage to other cells in the surrounding area that will allow it to grow in the absence of growth signals, or to not stop growing in the presence of signals telling it to stop growing. And all these combined contribute to the invasiveness and potentially the spread of the tumor. So sequencing technologies, genomic sequencing technologies, have allowed us to see the genetic sequence of the tumor and learn what are the drivers behind those mechanisms. And those mechanisms, which are strength in terms of having the tumor grow, can now also be used can be flipped and turned into a weakness, because we can identify these driver mutations and now have drugs that are available as targeted therapies, as Dr. Antonia had talked about, that can inhibit these genetic mutations in order to delay or stop the growth of the cancer. So Dr. Antonia talked about, and you guys may be familiar with EGFR and KRAS and ALK. And there are certain EGFR mutations which are associated with sensitivity to certain drugs like erlotinib or gefitinib or afatinib. And we know that we can now use these drugs. These drugs become a therapeutic option along the care continuum on patients who have these specific mutations. On the flip side, there's mutations in genes called KRAS, which confer resistance to those drugs. So if we detect a mutation in KRAS, we know not to give those EGFR inhibitors, and this way we can avoid giving therapy that won't work and would still confer toxicity. And finally, in the ALK rearrangement case, There are ALK rearrangements have been identified in a small subset of patients, and we have therapeutic options that can be very effective in that group. So our team, the Personalized Medicine Clinical Service, is here at Moffitt to help support physicians and other clinicians, much in the way when a MRI is ordered, a radiologist supports the clinician, or if a biopsy is ordered, the pathologist can support the clinician in interpreting and making use of that information. There's a variety of these different genetic tests that are available, some of which could be the single gene assays, such as just looking at EGFR or KRAS, in order to help select therapy or get patients stratified to different clinical trials. We also have a broader 26 gene panel that's some of our physicians are using for patients, which look at those core mutations as well as other known important mutations in cancer, which can potentially be used to help select therapy or get patients enrolled on clinical trials. And beyond that, there's other commercial panels which look at even hundreds of genes, which can be used along that same way to help potentially select therapy or to identify clinical trials for patients. And these tests all will we use a biopsy sample of the tumor in order to send it off for genetic analysis. But a new technology, something that's known as liquid biopsies, allow for the detection of these mutations through a blood sample. So the tumor genetic sequence can pool into the blood, and that can be detected by these liquid biopsies. So some of the reasons for physicians to order these tests are, of course, to look for targeted mutations which could help to select therapy or get patients enrolled on clinical trials, but also to look for specific mutations. For example, in the EGFR case, some patients will eventually develop a resistance or stop responding to that first-line EGFR therapy, even in the presence of an EGFR mutation. And we've now identified a specific mutation in EGFR, a secondary mutation, which is thought to be the cause of that resistance. And importantly, we now have a drug that is FDA approved in order to specifically act on that mutation. So by doing this genetic sequencing, we can identify when a patient stops responding to the medication and make an earlier switch to a medication which is known to be effective. So just to walk through the process of how this is happening here at Moffitt. So initially, the tumor genetic sequencing testing is ordered and the results are returned to the ordering physician and also to the Personalized Medicine Clinical Service team. Once the results are returned, either an expedited consultation report is generated and communicated to the physician to let them know what the results are and some initial interpretation. And alternatively, we have what's known as our Clinical Genomics Action Committee, which is our molecular tumor board, which brings together experts from across the disciplines, all different sorts of solid cancers and also blood cancers and other experts as well, to weigh in on really complex and complicated cases where mutations may be detected that haven't been seen before, and trying to help to understand and give guidance to the treating clinician about what actions could potentially be taken. From there, a consult report is generated and placed in the electronic health record, and communication between the oncologist and the patient can progress from there. Additionally, our team helps to support the actual attainment of these therapies. The ideal situation, I think, would be for patients to get enrolled on a clinical trial so we can learn more about how these medications work and who they work in. But in some cases, that may not be an option, and then off-label therapy becomes an option where the drug can potentially be given outside of its FDA-approved indication, and our team helps to prepare that. So finally, as you can see here, this is just an earlier snapshot of the Clinical Genomics Action Committee, our molecular tumor board. So as you can see, there's representation from, like I said, solid cancers and blood cancers, pathology, informatics, medical genetics, and basic sciences as well. So I feel really privileged to be here at Moffitt, where there's so much medical expertise and knowledge being done right at the cutting edge, especially within the thoracic group, where we have clinicians who are not only practicing the medicine, but also leading the science as well. So thank you.
Thank you, Dr. Knepper. Our next physician and panelist is Dr. Teresa Boyle. She joined us just 2 short months ago and is the newest member of our thoracic department and is a molecular pathologist. Her work consists of creating tests to determine which lung cancer treatment option is the best and which clinical trial the patient could possibly benefit the most from. So,
Thank you, Olivia, and thank you all for coming. It's really a wonderful opportunity for me to be able to talk with you. Pathologists are often called the doctor's doctor, so we don't get to see the patients very often. So it really is a pleasure to talk with you today. Let's see. There we go. I'm a pathologist, so I'm visual. I like pictures. I'm showing here a picture of lung cancer cells on a glass slide, and this picture was taken through a camera on a microscope. And these tumor cells were stained with PD-L1. It's a protein that hides the tumor from the immune system. And so with immunotherapy, you might look at the cancer cells themselves and see if they're trying to hide from the immune system. And so if you see more brown stain, that tumor is trying to hide from the immune system, and it's more likely that the patient will respond to immunotherapy. Now, this is not perfect. As you can see here, if you took a biopsy from the left side here, you'd have a very strongly positive case. But if you took a biopsy on the right side, biopsy core 2, it would look almost negative or weak. And that patient is not less likely to respond to immunotherapy. It's just that their tumor is expressing the PD-L1 protein in different areas. So we have to be very careful to interpret the PD-L1 results carefully. Even if PD-L1 is negative, the patient still might respond, but they're just more likely to respond if it's positive. And so likewise, we use the immunohistochemistry or the brown staining to detect ALK protein on the surface of tumor cells. And normal lung and most lung cancer cases are like the tumor cells on the left, where there's no brown staining. ALK is not normally expressed in lung. And so there's just 3 to 7% of patients with lung cancer that have ALK positive tumor. And these patients are going to be more likely to respond to ALK inhibitor therapy. And again, there's no perfect assay. There might be a few cases that are more like the cancer in the middle, where it's probably negative, but you're seeing a little bit of brown staining. And there you might want a backup method to check to see if there's an ALK driver to the cancer. And so here's a backup method called FISH, that stands for fluorescence in situ hybridization. And basically with this method, you are tagging the ALK gene with 2 fluorescent tags. And normally the 2 fluorescent tags, the red and the green tags, are close together in the tumor. So that's a negative case. But in cases where the ALK gene is abnormal and driving the cancer, like in the bottom picture, the red and the green tags have been separated because the ALK gene has been broken. And so these are the patients that are more likely to respond to ALK inhibitor therapy. And then if that's not enough, there's another method to detect not only ALK changes, but changes in other genes, such as the ROS1 gene, TRK genes, and RET genes. And there's probably more that we don't know about in small subsets of patients. And so if you actually look at the sequence of the genes, you can see what's normal and what's not normal. And this is called next generation sequencing or massively parallel sequencing. And we're using sophisticated machinery in the molecular lab here to do this. And so you're actually looking at all these genes and sequencing them at the same time and guiding the therapy with the results. So this just lists a sampling of assays that are currently in the works in the molecular lab. And I already showed you the PD-L1 immunohistochemistry, there is an RNA-based assay that we're planning to try this month to try to identify the translocations. And there's also something we're trying to develop called a liquid biopsy. And that's a not so fancy way of saying a blood test. And wouldn't you rather have a blood test than a biopsy of your lung tissue? And in some cases, the tumor sloughs off DNA into the blood or tumor cells into the blood. And with a simple blood test, you can look at the sequence of the DNA and detect changes that might be important for therapy, like a resistance mutation, where you might need to change the therapy with a simple blood test. And then there's new genes that are coming out that can be clinically important, like MET. And one of my favorites assays that we're developing is the proximity ligation assay. I'm working with Dr. Hora. He's done a lot of work for years to develop this assay to actually see the signaling inside the cell. So you actually really know what's going on inside the cell. And he's about ready to turn this into a clinical assay to see if it can help guide therapy. So many exciting things going on. And I realize there's a ton of information on this slide. I'm not going to go through it. I just want to highlight that we have an algorithm for our genetic testing where we're testing for the most common things like EGFR and ALK that we can target a therapy for as quickly as possible. We're trying to improve our turnaround time. And if they're positive, guide the therapy with that. Check for PD-L1 to see if it guides the immunotherapy. And then if it's negative, then look for other things that might be in just a few patients and do comprehensive genomic profiling and identify net changes. ROS1 tract translocations. There is a clinical trial at Moffitt for tract translocations that where there's a drug that has worked quite well in some patients, and so we need to identify patients with these changes. And so you can see on the edges there are many, many clinical trials going on at Moffitt Cancer Center. It's a very exciting place to be. I love my job. I love being here, and I'm happy to serve you. Thank you.
Thank you, Dr. Boyle. It's so great to see those pictures, isn't it? Our next speaker is Dr. Larry Robinson, and he is a cardiothoracic surgeon and has performed over 5,000 surgeries. His most recent research is looking for potential microorganisms that exist in a person's lung and can cause or contribute to lung cancer. Today, he'll share some more about this exciting project.
Thank you. I'm a thoracic surgeon, and I operate on lung cancer, have been here about 22 years. I am been blessed with the ability to operate on people and take out cancers, and most of those folks are cured. Unfortunately, only maybe 25 to 30% of the people who present with lung cancer have a localized cancer that allows surgical removal with a hope of curing those folks. Things have not really changed much in surgery over the last probably 3 or 4 decades, except that it's become safer, and we have a lot better idea with our imaging on who is a candidate for surgery and who has disease that's outside of a range of curing people with surgery. So I'm not going to talk about surgery because that's not particularly my interest as far as research is concerned. I've taken the other end of lung cancer, and I'm interested in potential causes of lung cancer. This is a laundry list of the current cancers that we know of that are caused by microorganisms. There's at least 20% of our cancers now are caused by various microorganisms. I won't list all of those. Most of you are probably aware, have heard of the name HPV, human papillomavirus, known to cause essentially all cervical cancer, a lot of head and neck cancers, and other cancers. The fact that you know that virus is involved in the cancer causation, well, that's great, but what can you do about it? Well, we have a tremendous opportunity to actually prevent and perhaps wipe out this cancer with a vaccine, which is extremely effective, the HPV vaccine, which we're pushing very hard to get young individuals to children and teenagers to use because it absolutely protects people against this. It's an excellent cancer vaccine. Now, that's where we currently are. There's a lot more things in the works as far as treating folks who have viral and diseases or viral-induced cancers. So this is an exciting point, but only 20% we know of currently appear to be caused by viruses or other microorganisms. Now you say, well, we know what cancer is caused by in lung cancer, just smoker. Well, yes and no. 1 out of 6 people who smoke get lung cancer, which is a lot. What happened to the other 5? Why did they dodge the bullet? Now they get other problems, but why didn't they get lung cancer? Well, what's some of the causes we commonly think of in terms of lung cancer? Associations, I should say. Smoking. Obviously, about 80 to 90% of lung cancer occurs in smokers. Although there's 28,000 people who die every year of lung cancer who are lifelong non-smokers. That's the same number of people who live in Temple Terrace that die every year of it. So they didn't smoke. So their cause was not smoking. Secondhand passive smoke, we think may have something to do with it. Family history, genetic susceptibility, maybe some radiation exposures, radon. You've heard of all that. That's a very small number. Other things that contribute to it, a declining immune system as you get older. Yes, we all get older, and our immune system also gets older. There's a lot of environmental carcinogens that can contribute to lung cancer. Chronic inflammation appears to be a big part, which smoking may actually add to chronic inflammation. Just having chronic obstructive lung disease also increases your risk of lung cancer. A lot of these go together, and what you end up, it activates what we call oncogenes. It appears that genes that you have normally, which are growth genes, get out of control, and you activate these genes, and then you end up with uncontrolled growth of lung tissue. Essentially, normal lung tissue becomes malignant. Or you may inactivate some of the other genes we have, which normally are supposed to suppress the cancer growth. Well, that's the conventional thoughts about lung cancer. The question is, what about an infectious cause of lung cancer? Now, if 20% of our cancer is known to be caused by a virus, it kind of makes sense that probably it's not going to stop at 20%. And probably most of our cancers will end up turning out to have some type of microbiological, viral, bacterial, so on, cause of cancer itself. And the reason I mentioned also this is in lung cancer, we just finished our first study, and we have several of these going on, where we actually screened. We looked for who are essentially the suspects. If you have a murder, what does the detective on CSI want to do? They want to find out who are the suspects. So we just finished screening frozen lung cancer tissue and normal lung, and found to our surprise that there's some consistent viral DNA. Now, DNA, that just means the virus was there in the cancer. It doesn't mean it caused it, because it could be an innocent bystander. But some of the viral DNA, which is very suspicious, is from a family called retrovirus. Retrovirus causes over 26 of the known causes of animal cancers. It's known to one of the members of the family causes a particular kind of lymphoma. We know that's the case in humans. And retroviral DNA have a number of properties that make them more likely to lead to activation of some of these oncogenes and may lead to cancer. And there's some well-known pathways that can cause cancer. And we have a lot of follow-up studies to see if there's really, is this just a interesting finding, or is there something really there? Now, when I say a viral cause of cancers, we're not talking about something like influenza. If somebody comes up and coughs in your face and they have influenza and you haven't had an immunization, chances are you're going to get influenza. Well, we have tons and tons of bacteria and viruses in our body all the time, but they don't cause disease. So just having a particular oncogenic virus doesn't mean you're going to get the cancer. For example, women who are HPV positive when they have their female exam, only 7% of those in their lifetime will get cervical cancer. The others won't. Hepatitis C or hepatitis B are known to cause liver cancer, but only about 4% of the people who have hepatitis C will ever develop liver cancer. The other 96% don't. That's because cancer is a multifactorial disease. And to give you a feel for what I'm talking about, This is what I've termed the perfect storm model of carcinogenesis. Now, most of the women in this audience have all seen the movie The Perfect Storm because the heartthrob George Clooney is in it. Well, those of you who haven't seen the movie, it's about George Clooney as a ship captain who goes out and 3 different storms come together to form the perfect storm. Well, that's what you have with cancer. I think one of the parts of the perfect storm will turn out in most cancers to be microorganisms. But you get chronic inflammation. You may have a genetic predisposition, various kinds of acquired physical changes. Obesity ends up with a lot of hormonal changes. Your immune system. God loved the immune system, but it gets worse as you get older, and there's a lot of things that can impair the immune system. Chemotherapy, various kinds that you had for other cancers, corticosteroids. A lot of those things, some of these immunosuppressive drugs that are given for rheumatoid arthritis or Crohn's disease, suppress your immune system. One of the most common causes of death after a heart transplant is lymphoma because you're immunosuppressed. Environmental factors, chronic infection, all of these things go together in various amounts. But I think the common finding we're going to have is in most cancers are going to be microorganisms that lead us to cancer. And once we find out which of these microorganisms is primarily involved, it gives us a great big giant target to help in treating cancer. Anyway, I think I'm very excited about all this, and there's a lot of people now who are quite interested in microorganisms causing cancer and the potential ways to use that information for treatment and prevention. So I think you're going to hear a lot more about that in the near future. Thanks so very much for coming today.
Thank you, Dr. Robinson. Our next speaker, Dr. Thomas Dilling, is the head of the Thoracic Radiotherapy Program here at Moffitt, and he will be sharing the updates in radiation therapy for lung cancer, specifically how Dr. Dilling's team personalizes radiation therapy and radiotherapy.
Hi. Thanks, everyone. Can everyone hear me okay? All right. I had a lot of options as to what to talk about today, and I think that a lot of people have heard or even sometimes have questions about different technological advances in terms of radiation delivery. People will go on the internet and say, I read about machine X versus machine Y or a CyberKnife or a TrueBeam or a Novalis or whatever. And the point is that there are many competing types of machines out there, and it isn't really the machine that is what would cure your cancer. In other words, people tend to think if I get the very best machine X, my chance for cure is higher than if I have machine Y. And some of this stuff is marketed to patients in that way. But a big fat, secret that they don't tell you is it's kind of a lie. The fact is that you have to deliver radiotherapy to the correct place and in the correct way to the correct dose without putting too much dose in all these other normal tissues. And the machine doesn't do that. The radiation oncologist does. Consequently, you can have a great radiation treatment plan from a quote-unquote lousy treatment machine or old quote-unquote treatment machine, and you can have a lousy treatment plan from a brand new state-of-the-art whatever it is, fill in the blank. And so rather than talking about all these different kinds of treatment machines and those kind of technological advances, I decided I wanted to change up a little bit. There have been significant advances in technology. Yes, there are many improvements in treatment planning to make your treatment plan be more sophisticated, more biologically accurate and correct in terms of calculating the dose and where it's going and how it's going. There's certainly improvements in treatment delivery with these new machines and so forth. And there's lots of fancy WYSIWYGs out there to even control the delivery of the radiation. It will turn on and off as the tumor moves with your respiration, so-called respiratory gating. Sometimes we use something like that. There's many such things like that. But I think that we're starting to come to the end of, in my opinion, of the possible technological advances that will really make a giant contribution. There are still some various technologies being developed, which I'm not going to talk about today. And some of them might be helpful, but many of them, I suspect, will just be small incremental gains. So where do we really go from here? Where's the newness going to come? And I wanted to talk a little bit about a research initiative going on in our department. We call it the Future of Radiation Therapy, or FORT for short. And it's an active research initiative in our department. It asks a number of different treatment questions, utilizing any number of different cancer types. As some of you may or may not know, we currently have 17 radiation oncologists in our department. 2 of us exclusively treat lung cancer, but basically any cancer you can name in the body has a radiation oncologist or 2 treating it. And our concept of this, again, it's asking a number of different research questions, but the overall concept is to utilize tumor biology, genetics, genomics, not only to personalize drug therapy, as you've heard about earlier from some of these earlier speakers, but also to personalize radiotherapy treatment. Treat radiotherapy like a drug. If a patient can have a tumor that's immune to drug X compared to somebody else's tumor, maybe tumor A needs a higher radiation dose than tumor B, even if they're of the same size and ostensibly the same kind. There's a lot of genetic things about given tumors that are unique. And how might that play in terms of radiotherapy? One thing that we're looking at is radiotherapy as immunotherapy. I came in a little late on Dr. Antonia's discussion, but one of the best primers of the immune system to tell it to fight a cancer is to use radiation. There's this effect called the abscopal effect. And what does that mean? Well, as you can see down on the lower left here, we have a treatment machine with a radiation beam going through to treat some cancer down in the pelvis. And it doesn't really matter where the cancer is. This illustration is simply illustrative. But the idea is that you're treating this cancer. Now, what happens is that causes this cancer to kind of break up into little pieces. And the immune cells, which are normally going around your body, are not recognizing the cancer when it's in its whole cell form. But when you break it up into little pieces, those little pieces can prime those immune cells so that they become activated against the cancer, little bits and pieces that they're exposed to. And therefore, those cells, as they're circulating around the body, could go somewhere like this lymph node up here that's outside the radiation treatment field and actually obliterate the cancer in that lymph node or in that bone over there. And this is a well-known effect, and it's been described in patients. I've had such patients. Dr. Antonia will tell you about them. You treat a patient with a cancer in their right lung, and a lesion in their left lung shrinks and goes away. This happens fairly commonly, and it's called the abscopal effect. So the idea is, what if we have an immunotherapy drug, and he talked about PD-1 and PD-L1 and so forth, and we add that in with radiotherapy, use radiotherapy to prime the immune system, use the drug to rev up the immune system, and the combination of the two things. So how does that work if you bring them together? Just as he talked about combining different drugs together, chemo A or agent A and agent B, you can talk about radiation as one of those drugs. My colleague Brad Perez has a particular interest in this, and he's actually working a little bit in Dr. Antonia's lab, and they're doing some active research in incorporating radiotherapy with immunotherapy. Another thing that we're doing in our department is we know that radiation sensitivity of tumors is variable. And it's not even variable across different tumor types. Like a cervical cancer might be more sensitive to radiation than, say, a sarcoma. We do know that there's variability that way. But even amongst non-small cell lung cancer, for instance, there can be a variable sensitivity. And so the idea is, can we create a genetic predictor of radiation sensitivity? Just as we would run a test to see if your tumor would respond to EGFR or ALK or something like that, we might say, okay, this tumor is on the more sensitive side. Maybe we don't need as high of a dose of radiation. Or maybe this one is more resistant and we need to increase the radiation dose. We're not there yet. We're working toward that. Currently, the way it is radiation, in a sense, is kind of like a cookbook. When you make a chocolate cake, you look up your recipe and it says heat the oven to 400 degrees and cook for 30 minutes or whatever it is. And the next time you have a patient that's a chocolate cake, you heat the oven and cook a certain amount. And so dose currently is pretty set. And it varies across different tumors. But what if we specialized it specific to your tumor, because your tumor is different than her tumor, and they're both receiving radiation, but maybe they need different dose. So my colleague, Dr. Torres Roca, has created what we call a radiation sensitivity index, or RSI. And basically, long story short, a number pops out the other side to predict the sensitivity of your tumor to radiation compared to somebody else's. And then the idea would be to, therefore, change the dose. You can see a number of different cancers running down this graph here. And you can see that even, for instance, across lung cancer, there's a wide spread in the RSIs of the different tumors that have been tested, suggesting that there's a wide spread in sensitivity or resistance to radiation. And there are some kind of areas that there's a little bit of a bimodal distribution of the numbers. But basically, you can see there can be a wide spread. So if your tumor's out here versus over here, maybe I need to change your radiation prescription up. We're working toward getting to the point of having a clinical trial for this. We're not quite there yet. There are a lot of intermediary steps to do, but I think that something like this is really going to be the future of radiation oncology. It's not just a treatment machine anymore giving dose X. We need to move specifically to the biologics of that particular tumor. And I could talk about other initiatives, but those are the ones I wanted to talk about today. So thank you so much, and it's good to be here today.
Thank you, Dr. Dilling. Holly Wilson is a licensed clinical social worker and has been in oncology for nearly 20 years. Through her experience, she has counseled thousands of lung cancer patients and their families and will share some of her insight today.
Welcome, everybody. Can everybody hear me okay? Yeah. There are 2 full-time social workers assigned to the outpatient thoracic clinic, Brianna Joyce and myself. Being an NCI designated comprehensive cancer center means we are charged with looking at the whole person. And that perspective is part of what social workers provide. The Institute of Medicine report, titled Cancer Care for the Whole Patient, states, psychological and social problems created or exacerbated by cancer, including depression and other emotional problems, lack of information or skills needed to manage the illness, lack of transportation or other resources, and disruptions in work, school, and family life cause additional suffering, weaken adherence to prescribed treatments, and threaten patients' return to health. We help patients and families look at their overall needs for care. We're part of your medical team. What do social workers do and how can they help me? There are many services and resources that social workers can provide to patients and family members. One of my doctors describes me as an air traffic controller. A cancer diagnosis can bring many new challenges, experiences, and feelings. Having support through the entire continuum of cancer care is very important. Social workers provide counseling to individuals and families who are coping with a new diagnosis, treatment, or adjusting once treatment is over. I hear fairly regularly statements like, "This is overwhelming, it's a lot to take in, I'm having trouble absorbing it all." These are all normal responses to a difficult situation. We perform psychosocial assessments to identify a patient's needs. There are many resources to assist with coping. We link people with those resources. We assist patients in making important decisions regarding their care by helping them identify immediate and long-term goals. We help the patients identify his or her goals of care and to communicate these goals to the medical team. This is not to advise patients what to do, but to help you think about the big picture and give voice to what's important to you and your family as you go through illness and treatment. We collaborate heavily with the medical team to be a bridge between patient and medical team. Sometimes a professional, neutral third party can help patients improve communication and open up dialogue among family members. We educate patients about advance directives. Advance directives are a written statement of a person's wishes regarding future medical treatment. We facilitate referrals for durable medical equipment, home health care, and hospice services. When a patient expresses concerns about costs associated with cancer care, we provide information about grants or programs to assist with gas or lodging when these programs have funding. We guide patients and help them navigate through cumbersome systems. We educate people about applying for Social Security disability or utilizing Family Medical Leave Act. We facilitate support groups. There are 2 face-to-face support groups offered at Moffitt, a general cancer support group and a caregiver group. And there's information in these groups in your packets. Social workers coach parents how to talk to their children about their illness and educate patients about our Families First program. The Families First program provides opportunities for families to bring their children and take part in a therapeutic activity as a family, and then attend an event in the community like a raise game. Most of all, we want to be there for our patients and families at those points when things are tough or you're facing brick walls. So please feel free to reach out and contact us. You can call 745-8407 to contact either Brianna or myself. Thank you.
Thanks, Holly. Our last physician speaker of the day is Dr. Diane Portman, and she's the chair of the supportive medicine program here at Moffitt. She has experience with anesthesiology, hospice, palliative medicine, and pain management. Today, she'll highlight how the supportive care program works alongside the clinical team to provide the best outcomes for patients and families.
Palliative care, sometimes called supportive care, is a key part of lung cancer treatment. This type of care is focused on helping you feel the best you can before, during, and after treatment, and is usually appropriate for all people facing lung cancer, no matter their prognosis. Talk to your doctor about what types of palliative care might be appropriate for you. What are the benefits of palliative care? Palliative care focuses solely on improving quality of life. It is appropriate to receive this type of care at all stages of your lung cancer journey. It may help you by providing relief from pain and other symptoms of lung cancer. In-depth communication to help you understand your treatment options and establish your treatment goals. And help with communication between you and your other doctors. This might mean providing certain medications and therapies to help you with your symptoms and side effects, counseling to help you cope with the stress of the disease, guidance in treatment decision-making, and much more. Who administers palliative care? Palliative care is provided by a team of palliative care specialists, including doctors, nurses, and social workers. While your other doctors and nurses may also help manage your symptoms, only palliative care specialists provide the complex symptom management needed for lung cancer. How do I get palliative care? The best time to discuss palliative care is at the start of your journey. Ask your oncologist for a palliative care referral, or you can search for a palliative care team at www.getpalliativecare.org. Every patient and caregiver deserves the support that palliative care has to offer. Knowledge is power. By being proactive during your treatment, you put the power in your own hands. For more information, visit mylungcancersupport.org. The American Lung Association is solely responsible for content.
So we introduced my talk with this video because I began to prepare some slides about what we do, and what I realized is this video that was actually produced by the American Lung Association really encapsulates beautifully what palliative care does. So the whole concept here is that you're diagnosed with a dread illness. It's very, very difficult. It poses a lot of challenges, physical, emotional, and spiritual. And we need to help you feel better as you battle your cancer toward either cure or life prolongation. And we tag team with the oncologist team all over Moffitt and chaplains and social workers to help you feel better. In palliative care or supportive care medicine, what we talk about, sorry, are you right clicking or left clicking? I may need your help now. Okay. What we do is treat what we call the concept of total pain. This was described by Dame Cicely Saunders at St. Christopher's Hospice in London many, many years ago. She's the founder of the modern day hospice movement. And she described total pain as that constellation of symptoms that put together create a platform for misery and suffering unless we address them. They come from the physical domain, so naturally pain from disease and a whole lot of other symptoms that many people encounter either as part of their disease or as part of their treatment, such things as breathlessness, nausea and vomiting, problems with fatigue, with sleep, with constipation, and the list goes on and on. We pretty much find that every single patient somewhere along the line will have one or more of these physical symptoms that are negative and need to be addressed so the patient and family members retain quality of life. There's physical decline that often goes with this and a deterioration in functionality. We want to optimize that so that people can be more like they have been and lead a normal life, pursue what's important to them. In the social domain, Holly, who spoke before me, demonstrated some of these issues, and we see so many problems with people's life changing within their family. They may have been the patriarch and provider. All of a sudden now, perhaps they cannot work, or they can't lead their family or protect and provide for their family the way they used to. Maybe having major financial struggles when they've been comfortable before, and they utilize all their savings. There can be problems getting to and from visits. When these stressors occur, we work together very closely with the social work team that's embedded in each of the programs at Moffitt, but also within our program to find solutions. There's also another kind of pain as part of total pain, and that's the psychological dimension of anxiety and depression. And what we see is sleep problems and function problems. Many people very much hesitate to acknowledge this because they may have been very self-sufficient, whole people before. They were not plagued by such stressors, and all of a sudden, with a cancer diagnosis and treatment, they are really finding their mood altered. We work very closely with the social workers, but also within our department, psychologists and psychiatrists, to give support when needed, including sometimes medication management, therapy, or counseling, even for a brief period of time if needed, to get people through that kind of pain. And then we have spiritual pain. Some people are religious, some people aren't, but a lot of people will find themselves questioning the meaning of life or their role in the universe when they have been hit so hard with a terrible illness and the challenges of treatment. We explore with them together with our chaplains how to refine their purpose in life. When we treat this constellation of elements of total pain, what we find is people are far more functional. They can more readily participate in an ongoing fashion in their anti-cancer treatments. Their satisfaction is improved and their quality of life and well-being are improved. If that's the case, it's the same for their family caregivers. So it's been studied quite a lot, the outcomes of, okay, all the ways I usually do this aren't working. Oh, so there's a number of outcomes that have been studied out to wazoo when people get palliative care along with their anti-cancer treatments. And remember, palliative care is treatment that can be rendered any time from the start of a diagnosis to wherever a cancer journey takes a patient. It goes along with anti-cancer treatments, does not take away anything else. So more rapid symptom relief, symptom control, fewer visits to emergency rooms, admissions to hospitals or the intensive care unit. If someone is admitted, usually the stays can be much shorter. Greater patient and family satisfaction with care overall when we attend to all the things that bother patients and families. Improved family well-being. And in a major important study that has been repeated now a number of times starting in 2010, when patients with a serious cancer diagnosis get palliative supportive care along with cancer treatments as part of the global care plan, they live longer and better. Thank you.
All right. Tom Burnham is a lung cancer patient and his wife Beverly, a lung cancer caregiver. Tom and Beverly are also LATTE research advocates, and we are so grateful for them for sharing their story today.
Good afternoon, and thank you for coming. When Olivia contacted me to ask if I would be willing to participate, I really wasn't sure what that involved, and she basically said, just tell your story. And I thought to myself, okay, so I was born in California. Oh, that's another story. But so I thought about this because I really didn't know what I was going to talk about other than my cancer story, and that's, I guess, what we're here for. I was told that most, if not all, of the audience members are cancer patients or caregivers. And so that's the role I believe Beverly and I are here today to talk about. In September of 2012, Beverly and I went to the beach over in St. Petersburg for a week. And shortly, the first day we were there, I started feeling tired, loss of appetite, and I had some nausea. It was not vomiting, but nausea feelings. And it seemed to last most of the week. Towards the end of our stay, I started feeling better, and we came home. At the same time, I had a feeling that I had maybe some food or something caught in my throat. So I went to my ENT. He sent me for a CAT scan of the throat. Everything was fine with the throat. However, the radiologist saw at the bottom of the film something that he felt was suspicious. So therefore, my ENT sent me to get a CAT scan of the chest. And as a result of that, I went back to my ENT's office, and they advised me that there was a spot on my lungs. And my question was, what does that mean, a spot on my lungs? Because I had been told early in life on x-rays on my chest that I had calcified I don't know what the word, but calcium deposits that were seen to be calcified. Something on my lungs that was not cancer anyway. So my ENT sent me that day across the street to see a pulmonologist. The pulmonologist made arrangements for me to have a needle biopsy at a local hospital in the area. And so Beverly and I, and at this time, when I got this information, Beverly was not with me. She was out working. And so I was by myself and not thinking that I had anything major wrong. And when I went to see the pulmonologist in the medical building, I'm in this hallway by myself, and all of a sudden it hits me, my goodness, something could be going on bad here. And had this feeling of, I had a lot of feelings, especially fear, is kind of, what do I do now? So I saw the pulmonologist. He made arrangements for the needle biopsy. Beverly and I, a day or two later, went over and spoke with the radiologist who was going to do the biopsy. It just so happened that before the biopsy was performed, I had an appointment with another doctor, a cardiologist, just for a regular checkup. When I saw him and told him what was happening, he said that he wanted to admit me to a hospital that day, so I could be someplace in case something happened, that I could be given the proper medical treatment. So, I'm taking his professional advice. So he says, you go home and hospital will call you this afternoon, which they did. So we went down and checked into the hospital. Now, all of this is happening so fast. Trying to wrap my mind around it. We get to the hospital and they decide, instead of doing a needle biopsy, they're going to do an actual biopsy where they cut you and go down with the scope and take a specimen. So I was under anesthesia. And then when I woke up, I was in my hospital room, and at the foot of my bed, I see Beverly, my brother, and my best friend standing, lined up. I'm thinking, gosh, Huey, Dewey, and Louie here. And I'm thinking, oh, this may not be so good. And, I'm sharing a room with the patient, so the curtain is pulled. And it's almost like on cue, from stage left, there came the doctor, the thoracic surgeon who did the biopsy. So he advised that, in the best way that he could, I'm sure, that his diagnosis, initial diagnosis, was stage 4 lung cancer that was inoperable, that could not be treated by radiation, and therefore my only recourse basically for any treatment was chemotherapy. I asked him, the first question I asked him, which I believe probably is a common question, it was, how long do I have? His response was, I'm not going to say, I'm going to let your oncologist answer that question. Okay. We didn't have an oncologist. At that point, he left. I believe there was some discussion. Again, my head is swirling about what to do. I think he did offer us some alternatives. Beverly can probably speak to that if she chooses, because I don't remember all of that. It just so happened we had a friend who is an oncologist and who had just retired. So Beverly put a call in to him and told him the situation. and his response was, well, for lung cancer, the only person I would send patients to would be Dr. Scott and Antonia at Moffitt. And I said, okay. So we contacted Moffitt. We were able to get in to see Dr. Antonia rather quickly the next week. We were talking about clinical trials, and I did not know anything about clinical trials. I didn't know anything. I didn't know about anything about anything. And so we talked about the profile and et cetera, and we went home and to wait for a phone call. Well, we got a phone call saying, unfortunately, I was not eligible for the clinical trial that was available for the arm. And then shortly thereafter, I don't know if it was the same day or the next day, somebody from Moffitt called and said that an arm of a particular clinical trial, there was a spot that had been vacated. Was I interested in accepting or getting involved? And Beverly and I talked, and he said yes. Felt their options were somewhat limited. So the trial that I got involved with consisted of, and please, I don't know how many of you are in trials or how many of you are just on regular treatment, and it's not important. But they explained it to us fairly clearly. We accepted, was signed up for the trial, and it began. The trial consisted of rounds of 2 chemo drugs and the clinical trial drug. And that was to be done in about 3 or 4 treatments on a short period, a week or 2 between treatments. Based on the results of that, they were going to do a CAT scan and see if there were any changes. During the second round of my treatment, I had some sort of reaction. Don't know what it was, but it was like an electrical current was going across the lower part of my back, and somebody was turning a switch on and off. So they stopped all the medicines, and then they put me on some pre-medications, and I did not have any more reactions. So after the results, after the 4 treatments, I had a CAT scan, and fortunately, the target tumors had reduced. One had actually disappeared. They couldn't see it anyway on the film. And so the protocol called for me to continue in the clinical trial without the chemo and just be on the trial drug alone. And I mean, I've been very fortunate that this week actually marks 3.5 years. And the interesting thing about that is the go is long. I mean, I've never had any, like I said, I never have had any association with cancer. I didn't have anything to compare it to. So I've been on the trial now for 3.5 years. Everything is going well. And that's pretty much my story of my treatment. And, I try and make it a short version, but Olivia asked me to send some photos. I wasn't sure why, now I know why. So I'm looking at them on the screen here. The picture in the upper left is the week that we were at the beach. The other pictures, it just so happened that after my diagnosis and before my treatment started, we had a trip scheduled to one of my daughter's home in the Midwest because their youngest was having a birthday. So, and we told my children about my diagnosis over the telephone. Beverly, I had contacted them in advance. I found out later. And so we went up, and it was interesting. It was emotional. We still celebrated. I figured I was going to lose my hair, so I decided, let's have a hair shaving party. So we sat there, and Beverly, I said, I want a mohawk first. So we tried to get a mohawk, and then my son-in-law in the lower right, he was already bald, so we shared that together. And the support that I received from my family and friends have been phenomenal. I kind of feel like, Olivia, where am I on time? Am I going over here? Okay, good. I will stop on that because I feel like other things that I may want to say would probably be more in the Q&A area anyway. So with that said, thank you for listening and taking your time.
Hi, I'm Beverly Burnham, and I had a similar reaction when Olivia asked us to speak and asked if I wanted to speak. And the reason is, I don't think I'm the face of the stereotypical caregiver, in as much as after the initial diagnosis and those first few treatments where Tom was, as many of you may or may not know, we've all heard the horror stories about what caring for a cancer patient can be and what undergoing chemotherapy can be. And for my part, Tom lived up to his end in that regard because he was very, very sick for a few weeks. So, visions of this being our life were, it was right there, up close and personal. But very quickly, once he was off the chemotherapy, our life evolved into, at first, when he was feeling so much better, I was very, very busy with wiping down the house and trying to catch every germ I could possibly catch and keep it at bay from him. We documented every single test, every single symptom. I had a binder literally this thick that I brought to every treatment. I filed every, test result. And then he just kept getting better and better. So soon all of that kind of dissolved into just taking care of our home, taking care of my business, taking care of the home that I owned, taking care of his mother. And I have less and less felt like a caregiver in the truest sense of the word. I've kind of been relegated to second string caregiver on Team Tom. And that has its own I don't know what the word I'm looking for is, but that is a whole nother realm. But I think it's important for people to know that it doesn't have to be all the doom and gloom. It can be. You're constantly very, very vigilant for every little thing that happens. Tom can tell you that he has a doctor for just about every medical discipline there is, God love him. And it's hard sometimes not to be terrified about a headache or a backache or whatever may happen. And at the same time, you wonder, should I say anything? I mean, this could be the cancer, it could be the treatment, it could be growing old. It could be nothing. And too often you'll mention it, and by the time you do something about it, it disappears, and they'll ask you, well, what is it exactly, and where is it? Well, it's not anymore. But my point there is that don't hesitate to tell your treatment team all of those little things that may be something, may be nothing. Don't be fearful if, for instance, you're on a trial, because that crosses our mind that maybe it will disqualify me for the trial. Just do it. Just make them aware. They can't fix it if they don't know it's broken. So I have had, conversely to what most people expect their life as a caregiver for a cancer patient to be, mine has been fraught with no few number of blessings, in as much as I became a bride, and I inherited 3 children and 7 grandchildren. So there's a bright side. There's a silver lining to every dark cloud. I think that's all I have to offer.
Thank you, Burnham. Our very last presenter is Dawn Owen. She's a triathlete and never smoker and a lung cancer patient, and she's here today to share her brave story with us.
First, I have to apologize. Please let me know if you cannot hear me. This just happened last night. I was so nervous. Ask Olivia. I was so nervous the month before I knew I was going to say yes to this. And I'm like, now I just look like an idiot because I can't. Anyway, look at those beautiful pictures. That's me. That's my life. Like Olivia said, I was a triathlete. In November of 2013, I actually finished an Ironman triathlon, which is 2.4 miles of swimming, followed by 112 miles of biking, followed by 26.2 miles of running. So I did that, and that is the bottom line. No, you didn't put that on. Of all things, my Ironman you didn't put on it. But anyway, so I did that in November of 2013. And not even a year later, in 2014, I was diagnosed with stage 4 lung cancer. How that happens to an athlete, to a triathlete, to a non-smoker, who knows? And I tried to get some answers today by the doctors, but it can happen to anybody, whether you're young, old, sick, healthy. It can happen to anybody that has lungs, and that's what I've come to accept. My journey has been long and hard in the last year and a half, but I have been very lucky, and I realized that. I did do traditional chemo for a couple months while they did genetic testing on my tumors. And during that month, I have decided that I'm never doing chemotherapy again. It was not for me. I was sick for 2 straight weeks, and I had 1 straight good week, and then I'd have to go back for chemotherapy. So for 2 or 3 months, I had maybe a month or a week out of a month that I could walk and not be sick. So I lost a lot of weight, and therefore I could not run, I could not bike, I could not swim. My life was taken away from me. My identity was taken away from me, and I didn't know how to deal with that, so I got very depressed. Luckily, the handsome gentleman right there, I met a week after I moved down here to Florida. I met him so he could take care of me, so I almost started crying when I heard your story. So we started dating over the summer in 2014, and I was sick, very sick. Again, how it happens is I don't know. I was very, very sick, would wake up screaming in pain because I had chest pain. I don't know where your pain was, but I had chest pain and shortness of breath. But I was in the best shape of my life. I have never been stronger, faster, or fitter in my life. In that middle picture, I PR'd in a 5K. I ran it in 21 minutes or something like that. And that was like maybe a month before I was diagnosed. I don't know how it happens. 3 days before I was diagnosed, I did a 9-mile trail run. And when I went into the hospital to figure out what was going on, they found out my lung was 80% full of fluid. Who knows? I mean, that just is a testament to the body can do great things, great things when it wants to, I guess. Are there more pictures? No, I'm tired of looking at that one. So anyway, I went into the hospital. By chance, somebody ordered a CT scan because of my pain, and it showed a spot in my liver. And they said, well, we advise that you go to the ER immediately because the spot on the liver doesn't look very good. So I went and they did more testing. And that night, all alone in an ER bed, just like you, all alone in a hallway, I found out I had cancer. I had just moved from South Carolina. I knew nobody but John. I was like, holy cow, what am I going to do? My family lives in South Carolina, so I had no one. So it's been very difficult, and I know I'm jumping all around. I feel like I want to say that it's very scary when you're first diagnosed. It's very scary, and you don't know where it came from, especially in my case. It just popped out of nowhere, and it ended my life as I knew it. And over time, I've had many dips and valleys. Medicines didn't work. Medicines that they told me would work for years and years and years lasted 3 months. And my body said, nope, we don't like that pill anymore, so we're gonna regrow our tumors now. I'm on my 3rd pill. Hopefully that will last a while. I'm hoping. But I didn't stop. That picture in the upper left corner of me in the front of a sprint swim, that was in May of last year. So diagnosed in October of 14 and doing a triathlon in May of 2015, I think is a real testament to how you just got to keep on going. I am way slower. And it makes me very, very, very angry and very mad. But I can still do what I can do. And John keeps reminding me maybe my lesson or my purpose in all of this and my diagnosis is to let people know that even though you don't move fast, you still got to move. You still got to be active. I have been a huge believer in how physical activity is sometimes, I'm not going to say all the time because I'm not a doctor or anything, but physical activity can sometimes be way more beneficial than any medicine ever. Not only helps your body, helps your blood flow, helps your muscles, it helps your mental aspect of things, which I think is so important. And I don't want to sound like a hypocrite, but there are days when I'm like, I'm dying and I don't want to go for a 3-mile jog today. I'm not going to do it. But you have to remember, this is today. You got to keep moving for today. So I am not one person that you're going to see on Ellen with all of her cancer guests on TV where they're all so positive and happy. And I'm never going to be on Ellen for that. But I think part of my lesson too is to tell people it's okay if you feel negative. It's okay if you're angry. I know nothing about my disease. My husband knows everything because I don't want to know. I just know that I'm so angry at what it's taken from me. But on the other hand, I have to look at what it's given to me. It's given me a whole new perspective on things. Palliatively, she's gone. Palliatively, spiritually, I've grown in leaps and bounds. You know, I'm so much more empathetic to people and sympathetic, and I hope I'm more of a motivator now that I can't do anything than when I could break PRs and podium on triathlon stages and stuff like that. So I just want to be a good motivator to people. And I think I wanted to say that I follow Tom I didn't know what to talk about when Olivia asked me up here. I didn't know what to talk about, but apparently I have a purpose, and that's to keep motivating people to do something. I hope you guys, whether you're first diagnosed, whether you're a caregiver, caregiving is just as important to be active as well. Whether you're first diagnosed or a caregiver or anything, just keep moving no matter what you do. Just every day, just do something. Just do something, please. Thank you.
All right, everybody, we've come to the end of our time, and I know some of you may have some questions, so I'm going to invite our panelists to the front, and if you have any questions for them, you might be able to ask them directly. But in your packet, there is an evaluation form. We'd be so grateful if you would fill that out to let us know how to keep improving these for future years and what you as patients and families of the lung cancer community are looking for. So you can drop those off at the registration table on your way out. Thank you so much for being here. Thank you to our panelists and all of our speakers and patients and caregivers. Have a great afternoon.
My question is directed to Dr. Robinson. I understand that lung cancer has many different causes, but I'd like to ask you about one particular item that's being discussed a lot these days, and that's marijuana use, specifically inhalation of marijuana. As you know, many states now are looking at legalizing marijuana. And the proponents of it seem to think that there are absolutely no risks involved to smoking marijuana, or at least not many. I can't think of any substances that you can set fire to and inhale the fumes of that are good for you. But I wonder if you know of any studies in particular regarding marijuana and perhaps increased risk of lung cancer. Thank you.
There actually have been some epidemiological studies where they look back at people who've used marijuana. And the few studies out there really have not shown any particular increased risk in terms of lung cancer. Not one of the reasons may be because people do not inhale as much volume of smoke in general as people do smoke cigarettes. No one's really sure whether that's the case or not, but to date, there hasn't been a correlation they can find in heavy marijuana users. And there hasn't been in the United States. It's mostly been in where it's been used for a number of years legally in other countries. So there hasn't been a correlation with it. Now, that goes far, far away from saying doesn't have hazards, because it has tremendous hazards, particularly in young people. And it causes a tremendous number of mental problems in younger people who have not completely developed the brains. And up to about age 25, the brain is not, particularly the frontal cortex and judgment and so on, and young people has not been completed. So the risk is particularly high in those individuals. There's a number of problems with motivation. People who are chronic smokers of marijuana, young people, my kids can pick them out of a crowd because it's a real problem, and it's not appreciated because it's not an acute problem. It doesn't have something's not growing off their shoulder, or they're not stroked out or something else. It's less obvious, but it's a real problem, and I am firmly against it as just a recreational drug because it has its own set of problems, and it's not without difficulty. The other problem has to do with if you drink alcohol, you have an ounce of alcohol that's equals to about one beer or one mixed cocktail or one glass of wine. The average person takes about an hour to metabolize that through the liver, and it's fairly constant in most people. So after a couple hours, you have very little of any alcohol left. Marijuana, when it gets in your system, varies tremendously. Some people, the next morning it's gone. Some people, 5 days later, it's still there. So we get to a lot of problems about, individuals who, do you want your nurse smoking marijuana? She may still be high when she comes in and takes care of you the next day. Or your surgeon, or your airline pilot, or your bus driver. You kind of go down the list. Your Uber driver. There's a lot of risks because it's not metabolized the same way, and it's variable in the individual. So I won't get into a long discussion about marijuana. Back to your question. Right now, there's no definite correlation with one, despite what you think may be the case, hasn't really proven to be the case, at least with preliminary studies that have been published.
Got a question from the audience. I've been on Tarceva for 3 years with great success. Will there be a time in the future to stop taking Tarceva? I have a deletion 19 mutation. Dr. Antonia is not here, but is anyone else able to answer that?
That's the $64,000 question, as you will know. No one's actually sure about that. That's the problem with some of these new agents. Not the problem, a good thing about some of these agents. People are out 3 years, and you say, well, do I still need to take it? And no one's absolutely sure about some of these items. Dr. Antonia mentioned in his talk, he said they're cautiously looking at the word cure. They're afraid to whisper that in people who have advanced disease, have metastatic disease, in other words, widespread disease. So the people who have an excellent response, they're actually afraid to stop it. And you're going to have a hard time probably getting people to enroll in a study where you continue yours and you're going to stop yours. We'll see if you have recurrent cancer. That's going to be hard to get people into that study. I sure wouldn't sign up for it. So I'm not sure what to tell you. The answer to that question is because that's a big if right now or question. Now, there are a lot of other therapies, and Tarceva may work for a while and then stop working. And there's a number of reasons why there's resistance. I won't go into all that, except the great thing, and I'm thinking as a surgeon, that it gets so exciting is the fact that there's so many options now. I mean, that is made, it's what makes us all very optimistic because there's so more options now, and the options are expanding rapidly, and you're going to see so many changes occurring over just the last couple of years. It's been very gratifying.
When I was first diagnosed, all my well-meaning friends all knew somebody who was cured by some method. Those being hydrogen peroxide. Have anybody ever heard of that? Okay. Oxygen, the ozone theory. No? Okay. Take lots of hemp oil, again, marijuana, in a liquid form. Have any of you ever heard of any of that?
There's lots of touted causes, and I should say cures of cancers of various ones. The problem about that is it's very uncontrolled. There's no, it's only anecdotal. It means this person said they did this because it did this, and so it must have worked. Or any of those. do they actually have effects that you could actually use? It's hard to say. There's been an enormous number of trials the NIH has sponsored on various kinds of remedies that have been touted for a variety of diseases, including cancer, that have been tested in a more rigorous manner, trying to look objectively, do you actually have an effect, or is this something that happened by chance, unrelated to it? If you got cured and you got better because you were taking such and such, and you also drank milk at the same time, it doesn't mean the milk added to it, just what happened one time. So, yes, I've heard of all those myself, and I could name dozens more.
Well, I'm sure you can.
There's a whole book I've read on hydrogen peroxide. You can use it. Supposedly it works well on age spots. I put it on every day for twice a day. So there's a lot of things out there. Can't tell you with any certainty. I can tell you with a lot of certainty that there's a tremendous number of new things that are being used, as Dr. Antonia and others have mentioned, now that have very good track records and rigorous trials that are causing people to live a lot longer free of cancer, as we've heard.
Thank you.
We have time for one more. Any other questions?
First, I'd like to thank you very much for the presentation this afternoon. It was absolutely excellent. I was diagnosed with prostate cancer in 2007, gone through the hormone therapies, and most recently the intravenous taxiturn, which gave me peripheral neuropathy, took away my ability to walk, so that didn't become an option. I've gone into oral chemos, taxiturn, Zytiga. They don't seem to have lasting effects. My body seems to reject them on a regular basis. I've got cancer in the V of the bronchi that the tumor is beginning to encroach on airflow. So I'm here today. I've got an oncologist and a pulmonologist, and I'm here to begin with. I had a endoscopy done here at Moffitt a year or so ago that told me, what the story was. I'm from Punta Gorda, so I'm 100 miles away, and it's difficult to commute here and on a continuing basis. But a long story short, who here, number one, what treatment, radiology, laser, or whatever, could be done in that area? And if I were to begin some treatment here, what department and what phone number would I need to get that started? I don't know who to direct the question to. Everybody's got a specific.
Well, first of all, for endobronchial obstruction, in other words, tumor is blocking off part of the bronchus, sometimes you can do something through a scope, as in laser, and there's cryoprobes and a number of things. It depends greatly on whether you can actually see past. Is there still an opening into that bronchus?
Yes, there is.
And so laser therapy may be as a palliative option. This is not a curative thing, but as a palliative to open things up is frequently may be available. That's usually done by our pulmonologists, do most of that here. And they do it, from time to time, laser therapy, and you have to be evaluated for that. Sometimes people can have, depending on where it's located, radiation therapy, external beam radiation therapy may open up areas that are not amenable to any type of endobronchial inside the bronchus treatment through a bronchoscope. So those are options, but there's a lot of ifs and ands, and maybe him and maybe not there, and there's a lot of details to it, and you have to look at it, look at CT scans and see exactly what's involved with it. And then, of course, systemic therapy may help shrink tumors, which make it various kinds of systemic therapies, and the variety of ones we've been talking about today, not just traditional chemotherapy, but targeted therapies and immunotherapies and all these other may shrink a tumor so that it opens up itself. But in terms of localized treatment, it may be something that a pulmonologist that we have here that do these types of endobronchial treatments may help. And occasionally even have somebody will put in stents, put a stent inside, an actual expandable stent for that. Anyway, to get an appointment for someone is to call the main number at Moffitt for a new patient appointment number. And is that in your list there on the
813-745-3980 is our new patient appointment center, and that would be our portal of entry.
Great. Well, we are come to the end of this. If you've got any additional questions, I'm sure you can walk up and ask any of our panelists on a one-on-one basis. But thank you so much for being here. Please feel free to drop off those evaluations on your way out. Thank you very much.